Have you ever heard a family member say that if they're not in the ICU, then that must mean that they're doing okay? As nurses, we hear that all the time. But the reality is that just because the patient is not sick enough for the ICU doesn't mean that they are stable. Today, we are talking about the gray zone area, which is the step-down units, the intermediate care units, that's the IMU, as well as the telemetry units. We'll explain what family members often misunderstand, what nurses are monitoring for in this unit, and why not ICU doesn't often mean out of danger.
Welcome to Married to Nursing,
the podcast where we pull back the curtain on healthcare.
Hello everyone, welcome back to Married to Nursing. I'm one of your hosts, Anna, and this is my husband,
Armand.
And together we have been nurses for decades. Although I have since transitioned into entrepreneurship, but my husband is currently still practicing as a nurse. And right now he's in the OR department, although we have both worked in several departments in the hospital. So together we are joining our experiences and bringing our expertise in the nursing field to help you as a patient, family member, or caregiver to be more informed in the healthcare system so you can make better decision or be in a better position to advocate for yourself while you are in the hospital. But before we get started, a quick disclaimer. Anything that we share on this podcast is for informational and educational purposes only. We will not be sharing any patient information or anything that's specific to any patient. We are using or sharing a collective of our experiences together. Okay? So let's jump right into it. We are going to be talking about what it means to not be ICU sick, but not stable. All right, so let's get started with the basics. What does it mean when we say that a patient is in the gray zone?
Okay, a patient that is in the gray zone. So when a patient comes to a hospital, the admission point is most often the ER. So depending on the patient condition, they either go to the med-surg, which is the medical surgical unit. They can go to observation, or they can go to IMU, or they can go to ICU. So a gray zone often is a patient that is in IMU. Basically, it means that the patient is sick. Is too sick to be in the med-surg unit.
Okay.
But is not sick enough to be in the ICU.
Oh, okay.
So the admitting doctor or whomever saw the patient in the ER have to make that decision. Okay, can we send this patient to the regular floor, which is med-surg or telemetry unit, or do we have to send this patient into the ICU or into the IMU? And that is determined based on the patient conditions, patient's vital signs, what brought the patient into the hospital, and different criteria that they look at before they make that decision.
Okay, and that's going to be my next question. So what are these things that they look at specifically? What are some of the things that they're looking at to determine if this patient needs to be in this IMU, in this gray zone area?
Okay, so the first thing is, you look at the vital signs, right? What is the patient blood pressure, respiratory rate? What is the patient there for? Is the patient there for because the patient came to the hospital because of some acute respiratory distress, or like a patient is septic? Well, septic means that there's an infection going on somewhere in the body, and that is leading to some different cascade of events. The first thing I would say is you look at the admission diagnosis and the labs, right? And the vital signs. If a patient is breathing way beyond what is supposed to breathe, do they require some sort of respiratory aid? Like respiratory aid can be, do they need oxygen to be administered continuously for them to catch their breath?
But doesn't the medical unit also administer oxygen?
True, the medical unit administers oxygen, but there is a certain dose. In the medical unit, you give 2 liters of oxygen through a nasal cannula.
Okay.
You can bump it up to probably 6, but at a certain level, the body can only absorb so much, right? So now they have to upgrade it to a different device, a different way of administer that oxygen. We can talk about a non-rebreather, which is a special mask you put on the patient. If the patient cannot tolerate that, then we go to the BiPAP machine. It's a machine that we put on a patient's face, and that is constantly administering oxygen.
Okay.
If you move past the BiPAP, then you are intubating. So if a patient is already needing that non-rebreather machine that I'm talking about, or non-rebreather mask that I'm talking about, then they need to go to IMU.
Okay.
Because they are like, progressively
Getting worse.
getting
or
worse
sicker.
and worse. Yeah. And when I work in the IMU, most of our patients will end up, will come to us because they started them on a non-rebreather mask.
Okay.
And they're like, okay, they are not tolerating, so we have to put them on a BiPAP machine. And that BiPAP machine requires a different level of assessment and care. You have to constantly watch the patient.
Okay.
Because if they're on that machine and they keep getting worse, the next level is ICU.
Okay.
So they come to you in the IMU on that machine, and you just monitor them, do all the treatment that you need to do until they get better. If they don't get better, then they go to ICU. Okay.
Okay.
So that's one example. If a patient come in with what we call CHF, which is a heart failure related to fluid being around the lungs, and they are breathing, but around the heart, they are breathing, but they are not expanding lungs well enough to oxygen in the body. So that's one of the main reasons people end up in IMU.
Okay.
CHF.
But if it's a heart problem, wouldn't they want to send the patient immediately to ICU as opposed to the IMU, the step down unit?
No, because some of the intervention that we can do in IMU, most of the time will help get rid of the problem, the CHF problem.
Okay.
Because the patient can be in CHF, which is CHF
heart failure, congestive heart failure.
Congestive heart failure. Patient can be in congestive heart failure, but the vital sign can still be okay. Blood pressure can be fine. Respiratory rate can be fast, but if the blood pressure is not too low, where we're talking about the mean arterial pressure, which is the value, how well the heart is perfusing the organ. If it's still okay, then you can keep them in IMU. And you give medication, you do treatment that get rid of that excess fluid.
Okay.
From the body. And if you're successful, then they can go back down to the medical
unit. Okay. That's when they come to me.
The one thing that often happen is where a patient will go from IMU to ICU is that the blood pressure drops so low that they need medication such as what we call a pressor. A pressor is a drug you give the patient to help increase the blood pressure.
Okay.
So you don't want that blood pressure to drop below a certain level, because if it drop below a certain level, then there is not enough blood going to the organ to sustain life.
Okay.
So you have to move them to ICU so they can get those pressors and keep that blood pressure at a certain level so they don't deteriorate any further.
And they can be monitored closely because usually ICU nurses tend to have maybe just one or two patients depending on the level of acuity in the ICU of that patient.
ICU is 1 or 2. IMU, we don't go past 4. Med-surg is
7.
6, 7.
7 when they're really short staffed.
Yeah, but 6. So because those intervention, those patients are super sick, you need more focus, more hands-on to keep them safe and alive.
Okay. So I understand that one of the biggest misconceptions that family members have has to do with the step down unit. So what do families usually assume when a patient moves out of ICU into the step down units?
Well, most of the time, family member will think, okay, because they are moving down from ICU, that means they are better. But like you said at the beginning, IMU is a gray zone. Is a place where anything can happen. A patient can come from ICU to IMU nurse, and they can go back to ICU.
Right.
So the nurse that is taking care of that patient at that level has to be extremely vigilant, where if anything is going wrong, they can capture it quickly enough to send the patient back to ICU. What we would like is for things just to go smoothly, where the patient is getting better and better
They keep
and better,
getting downgraded.
and then we move on to the lower level of care.
Right.
In IMU, when we have patients that are like, talkative, can breathe on their own, like they don't, let's say they started on a BiPAP and then we brought them down to just a simple nasal cannula, which is the one you put in the nose with 2 liters, and they are able to talk, they are able to feed themselves, they don't need any assistance, they are even able to use the restroom. Then that means that, okay, it's time for you to
downgraded
to be downgraded to the regular med surg.
Okay, so when a patient is brought down or downgraded from the ICU to the IMU floor, does the nurse that's taking care of that patient now still maintain 4 patients, or did they give the nurse less amount of patients now, because this patient that's coming down from ICU is technically still like one leg in the ICU, one leg out. So
no, you still get the 4 patients.
You still get 4 patients
because that's the ratio, 4-1. At least when I used to work in IME, that was 4-1. I don't know if things have changed ever since then, but no, you still get that. So the whole unit will look at the ratio. Everybody's, if a patient is downgrading, they will see which nurse doesn't have that whole 4, because it doesn't always mean it's 4-1, but it doesn't always mean that we always get 4, right? We can get up to 4. So depending on the unit load,
right,
you can, sometimes you get lucky, you get 3. You can be extremely lucky, you get 2, but don't be too happy when you get 2. That means they know that you have 2 and any admission is coming to you. Yeah.
And I guess let's assume that everyone had 3, or some people have 4 and some have 3. Then they would look for who has the patients that are more stable, like the walkie-talkies that you're talking about, that are ready to be downgraded to the next floor. And that would be the nurse that would now get this patient that's coming from ICU.
So that's when, it's very also important for the charge nurse to really know what level of care every patient require, to have a better understanding of the unit, and so to distribute the load fairly, accordingly.
So what happens when the patient arrives on, let's say, from the ICU now to the step-down unit, and they just rapidly start declining, maybe less than a couple of hours that they've been in the IMU? Do they get sent back immediately to the ICU, or do they keep them? Do you guys usually keep them there, stabilize them, or what happens?
No.
Hey, Anna here, asking you for a big favor. We need your help. In order for us to grow here on YouTube, we need you to subscribe if you haven't done so. That will really help the algorithm push the video out in front of more people who can benefit from the conversations, the topics that we'll have here on this podcast. So if you know someone who has been a patient, a caregiver, or a family member that you know who has been a patient in the hospital or across the healthcare system, please share the podcast with them as well. And if any episode that you're watching resonates deeply with you, I want to encourage you to also like the video. But first of all, start by subscribing to this channel, to this podcast, if you haven't done so already. That would really help us out to get these videos, these conversations in the view of more people, and to help the algorithm. So thank you so much. We truly, truly appreciate your help and your support, and we do not take it for granted. Now, let's get back into today's episode.
Best thing to do is to send them right back to the ICU. The only time we will have to keep them there is if, let's say, there's no ICU bed.
Okay.
But the patient start declining, let's say the patient require pressure, blood pressure is tanking, and the patient needs pressures to be stabilized, or patient has to be intubated. No, you intubate, or you start those pressures and you send them back to ICU immediately, because IMU nurses are not often trained to manage pressures to a certain. There are certain pressures that IMU nurses can manage.
Okay.
In some department, in some institution also, but there are certain frequencies and protocol that it require an IMU nurses to follow to you send them back there.
So what would you say, in your opinion, is the biggest difference between the ICU and IMU?
The biggest difference is the patient's condition. So a patient that is ICU is either intubated or is on organ failure, especially the acute kidney injury, where they require what we call a RIT, which is renal replacement therapy. They are like basically on dialysis.
Okay.
You put them, they go back there because of that. They are super septic, where all the organs like heart rate is low, blood pressure is low, respiration is low. They are intubated. They are not moving or anything like that. So in IMU, we don't see all those things. You can see sepsis, but it's not as bad. Let me say.
Maybe it's towards the beginning stage.
Towards the beginning stage, the patient is still okay. Temperature is spiking. Lactic acid or those labs are, going up. Most of the time, actually, I think all the time, when a patient is experiencing sepsis, lactic acid is spiking, you will see that in kidney functions also.
Okay.
The kidney function will start declining. The patient will stop peeing. Let's assume a patient has a Foley.
A Foley catheter.
A Foley catheter.
For those who cannot urinate.
Yeah, right? For those who cannot urinate. You, as a nurse, you expect to see a certain amount of urine in the bag every hour or every 2 hours. So let's say you come, first hour is, I don't know, a little bit amount. You come back an hour later, it's still the same amount, and the color of the urine is just different. Like it's not
cloudy.
Is dark and all that. You need to start what's going on here? What's going on here? So that means the patient can be going into kidney failure. So I call the provider. This is what you're seeing. You look at the labs. Okay, if they need to be in dialysis.
And that's after you've already physically manipulated the catheter, checked, and make sure that it's in correct position and all of that.
You check the bladder. Is the bladder full, but the patient is not draining? Like you say, catheter placement and things like that.
Okay, so I want us to talk about this phrase that we've been using, not ICU, but not stable. I know it can be confusing. So in your nursing perspective, what does that really mean when we say that, this patient is not ICU sick, but they're not stable?
So ICU sick, but they're not stable. So it goes back to ICU sick, but not stable.
Sorry, not ICU sick.
Not ICU sick.
I'm sorry, yes, not ICU sick, but not stable.
So it goes back to that gray zone. They are not sick enough to go to ICU, which means we can still manage that patient in the IMU, right? And it happened like, okay, a doctor or the doctor that takes care of ICU, the intensivist, will look at the numbers like, okay, ICU is full. We can still manage this patient in the IMU for the time being, right? And they will give certain orders and we'll follow. And it goes back to the nurse being vigilant, like, really now out of the 4 patients, that patient becomes your number 1.
Right.
You are looking at that like at that patient like a hawk, making sure that everything is going smoothly, vital signs are not changing, patient is stable, etc., etc. And sometimes a patient can be stable, not ICU sick, and things turn to the worst in a split of a second. Everything will be fine. Okay, we don't have any issue, and the next thing they're having a heart attack.
Right.
Or new in an IMU, and those type of situations you cannot predict. It's just what it is. And if it happens, and if you catch it on time, you call the code, you call the rapid nurse, and you do what you got to do
to make sure the patient is okay.
Yeah.
I remember how even working in the medical unit, when we start having patients that are declining, And sometimes we'll call the doctor because nurses pick up these things. They're the ones that are with the patient 24/7.
Yeah.
So we tend to see or notice these things earlier, which is something that we discussed in previous episodes. And we can call the doctor sometimes, and the doctor is like, no, let's leave them, kind of like what you're saying. No, let's still leave them there. And the nurse is like, I need to send this patient
out.
So at least IMU, maybe not ICU, but at least to IMU, because we can see that what's coming ahead.
Yep.
If this patient remains on this floor, it's going to be disaster. As unfortunately, sometimes that's what ends up happening, because this patient was not promptly moved to the IMU or IMU. And again, unfortunately, it's sometimes because there's no bed or there's this nursing shortage, so there's not enough staff, nurses, to take the patient in IMU. So they want to see how they can manage the patient in the medical unit, and vice versa, also in the IMU unit, instead of sending the patient to ICU.
But this is always, it's always about scarcity of resources.
Right.
So it would be lovely if we can take care of everybody, the way they need to be taken care of. But sometimes we have to make adjustments depending on the resources that we have available at that point in time. So yeah, it does happen. Like, patient can come in. I remember a situation, patient was fine, was stabilized and everything, stabilized, brought the patient to IMU, and the patient was going to wait for intervention the next day. The patient was perfectly stable, IMU stable patient. In the middle of the night, the patient coded.
Oh wow!
So it was like,
did they have a heart attack or stroke?
Yeah, they had a heart attack in the middle of the night. In that instance, everything was fine, perfect. The patient didn't need to go to ICU. The patient was perfectly fine in IMU. The patient did not require any extra intervention or level of care. But unfortunately, things just turned from bad to worse quickly, in the split of a second. Yeah.
And that's the thing about being in the hospital. Things can turn very quickly, So when these patients are in the IMU, are they hooked up to the machine? Because I know when they're in ICU, they're connected to the monitors 24/7. So are every patient in the IMU department connected to the machine as well?
Every patient. Okay. We connect you to the monitor in the room.
Even the walkie-talkie ones?
Yes.
Okay.
We connect you to the monitor in the room, and the monitor actually transcribe your heart rate to the nurse's station. So we have a monitor where we can see everybody in the unit's heart rate.
Okay.
So you see that, and that's also another signal. Those things have alarms.
Right.
So they are set up. If a patient's heart rate is going faster than normal, it will alarm. If the rhythm change, it will alarm. There was one that we always, VTAC. Patient will go into VTAC, and patient heart rate will be normal, what we call sinus rhythm, and then all of a sudden, and then we'll be like, oh, we have 6 bits of VTAC or 8 bits of VTAC, and some patient will show that quite frequently, but then not quite frequently, like once in a while, but then all of a sudden you see it once, and then 30 minutes you see it again, and then all of a sudden 15 minutes you see it again. You're like, okay, what is going on here? The patient has what we call atrial fibrillation, so the heart is just quivering anyhow. So that is a dangerous thing, atrial fibrillation. So you have to get on it quickly, start giving the necessary medication to bring the patient back to normal heart rate.
Yeah, and these are things that most family members don't see, because these are behind the scenes of nursing care, that even to work in the IMU unit as a nurse, you have to be vast, or you have to be trained in heart monitors and knowing the different heart rhythms, the patterns. But in the medical unit, it's not needed.
No.
All right, me working in the medical unit, some patients will have a telemetry monitor. That's a heart monitor that they place the electrodes on the patient, but the monitor is being monitored, or the machine, the rhythm is being monitored by someone else, a telemetry technician. somewhere else that is keeping an eye on it for you.
Mm-hmm.
And oftentimes we'll get the call, oh, your patient is exhibiting
This and that.
this and that. And sometimes it's because it came off of the patient or
Yeah.
whatnot. But for you guys as the IMU nurse, you have to be trained in
that.
noticing these rhythms. You don't have someone.
The one catch is because on the med surg you have 6 patients and above,
Right.
so you can't keep up with all those.
All
so
that.
they kind of delegate that monitoring to another person.
And these patients are also more stable.
Yeah,
so
they are
they're
more
just trying to
stable.
keep
Mhm.
an eye on the rhythm.
On the rhythm. For
Right.
their rhythm to change so fast or so quickly is very rare. But IMU rhythm changes all the time.
Right. So that brings me to my next question. What causes you to, as a nurse, as an IMU or step down unit nurse, to call the provider immediately?
Like we talk about the rhythm change, that's number one. That's not number one, but that's one of the things. The patient started developing atrial fibrillation. You call right away. A patient throws in VTAC, those bit of VTAC that I just spoke about. You call right away. If there's a history of it, they'll be like, oh, it's okay. But if the frequency has changed, then something needs to be done. Temperature spiking, patient developing sepsis. You need to call right away. Patient urine output, like the example I gave her about Foley catheter not producing urine. So you got a patient at 6 a.m. and by 12 they haven't peed. Okay, you need to get on top of that. You're looking at the blood pressure, especially that MAP, the mean arterial pressure. If a patient's blood pressure is unstable, especially on the low side, and that the normal MAP should be between 70 and 100, right? Anything below that, you need to start paying attention to it. I hope I'm not going to technical here.
I know in the medical unit, we tend to just focus on the blood pressure and not the MAP.
I learned that when I started working in the IMU. I was like, oh, why everybody talking about MAP? Eventually, I started talking about MAP, like, all the time. So you look at the MAP, and MAP drops when a patient's blood pressure is that, like, especially the top number is like going below 90, 80, 70. A blood pressure of 70, you're like, okay,
right,
you need to start running.
All right.
It's a plethora of things. I list maybe 5: sepsis, temperature change, heart rhythm change, urine output, blood pressure, MAP. And those, just depend on the patient that you have too. If you have a patient that is on dialysis, it just make everything. Or if you have a patient that is on congestive heart failure, it makes everything more pronounced, because those are like less stable patients.
Okay. So real quickly, in the IMU unit, do you all still call the rapid response team, or is there a team in the IMU that takes care of that? Like, you don't have to call the rapid response?
No, even in ICU they call the rapid response team. Yeah, we still call the rapid because some of those drugs you will give a patient during a code, you kind of have to be trained for them.
Okay.
So you call the rapid response. In ICU, if you are trained to give that, you can give it, but you have to know how much of those drugs you are giving, so you don't basically kill the patient.
Right. I remember those times when I was working in a hospital and would hear a code blue over the intercom in ICU and the IMU, and it's like our heart just skips a beat, because the last thing you want is for a patient to code in ICU, most especially, and then next in the IMU, because these patients are already so sick and they're coding, and it's like, oh my gosh, I hope they make it.
It's funny you say that, because ICU coding, when a patient code in ICU, sometimes I find it very difficult, because a patient, let's say a patient is already intubated, so when a patient code in ICU, the code just shows up on the monitor. All the numbers changes. But in the IMU, you don't focus. It's not so much on the monitors. It's like what the patient behavior is. So if you don't know, if you don't get trained as an ICU, to identify those changes in the data that is suggesting code, you may not know.
You miss it.
You will miss it. So I find it very challenging sometimes, at least because I'm not an ICU trainer. So
All right. So let's talk about what families see versus what nurses actually see. Why do some families think that nurses aren't doing enough?
Because family members don't see the background work. They see us just come into the room, maybe give medication, change a patient, change the medication on the pumps, and just move. But they don't see all the other things that we do in the background, like monitoring this. Like when a family member can be sitting there next to the patient, you the nurse should come in one glance. You look at the monitor, you look at the patient, you look at the Foley catheter, you look at all the machine, like 1, 2, 3, 4, 5. Like with one glance, you look at all those numbers, and especially with experience, you just immediately incorporate all those things in and say, okay, everything is
process
fine.
it quickly.
Process it quite quickly, and you just move on. The only time I guess family members say that, these people are really doing something, is when any of those number changes and you start like tinkering with the machinery. What is going on? And then you start pulling up your phone and you're can I I'm looking at something, can I have a second eye to help me make a decision, so that's why.
Right. And also family members only capture just snapshots because they're not usually there 24/7 or even in a 12-hour period. It's the nurse that's seeing the trends for the whole 12 hours where family members are coming in and out. So they only see snapshots of things, whereas
we have to give kudos to family member who stays there, like 24/7. They don't move, and they communicate. They talk to the nurse, they talk to the doctor, and eventually they kind of capture all those little subtle changes, and they realize, this is not so easy. These people are really,
and they become involved too in the patient care or in their family member care, because they're able to even tell the oncoming nurse who is not familiar with this patient. They're even able to give that nurse even more information about how the patient has been acting or trending or things like that. So you're absolutely right. Kudos to those family members. We see you, we hear you, we acknowledge your hard work and your love for your family member. All right, so I have a rapid fire fun facts or fiction for us to play. So I'm going to give you a statement and you tell me whether it's a fact or a fiction. Ready? All right. If a patient leaves ICU, they are out of danger. Fact or fiction?
Fiction.
All right.
Totally.
Stable means healthy.
No, stable doesn't mean healthy. Stable means that you are out of the wood. A patient is out of the wood at that moment.
The immediate danger. But not, it's kind of like when the EMT comes to respond to a 911 call or whatnot, and it stabilizes the patient enough to transport them. But it doesn't mean that the person is out of the woods. Okay. Patient can decline quickly after seeming fine.
That's true.
Fact?
Yeah.
Okay.
That's a fact.
Nurses often notice problems before monitors alarm.
Yes, they do. Nurses do. But I can say that it goes vice versa. The nurses, because the monitor can alarm and get the attention of the nurse, and the nurse comes in and see, what is going on. And sometimes the nurse can just see the patient before the monitor start alarming, depending on what they are doing at that time.
Right. So last question, being awake and talking doesn't always mean someone is stable.
Yes, true. That's a fiction. The patient can be awake, talking, and
things are happening
in the inside that you don't, because things deteriorate in the inside before they manifest themselves on the outside. Everything happening behind the scene before it comes up to the surface, right?
Right.
So the things that are happening in the back, like the example I gave, person was fine, all the number looks fine, it's nothing you have to do, and in the middle of the night, the code, right?
Right.
So yeah, things happen in the background that we can't always catch.
Okay. All right. So if there's one thing that you want family members to remember from this episode, what would it be?
Being downgraded from ICU doesn't mean that the patient is out of danger.
Okay.
Even leaving the hospital, right? It doesn't mean the patient is out of danger. There's still things you have to continuously do to take care of yourself and the patient. So ICU, I would say that I wouldn't want anybody to be in ICU because it's, a person is receiving drug to keep blood pressure up, which is not conducive to life, right? But we do those things until the body can take over,
Right.
So yeah, one thing is don't go to ICU.
Well, they can't help it.
True.
And even if they do end up in ICU, they're in good hands. They have skilled doctors, nurses, a health team that is there taking care of those. Those ICU nurses are smart.
It didn't come the right way out of my mouth, but yeah, ICU is when you go to ICU also, and when a patient goes to ICU, they are being well taken care of.
Right. 24/7.
24/7. Everything is monitored to the T.
Yeah.
To every line is crossed, every I is dotted.
Yeah.
To make sure that person comes back
out of it.
Yeah.
All right. Well, that is it for today's episode. So if you've ever wondered why nurses seem so focused on these small changes, this is exactly why. Because those subtle small changes can lead to bigger problems. So these nurses are paying attention to every single detail, to the monitor, to patient behavior, to make sure that they catch these things before it blossoms or into a bigger well, maybe not blossom, before it becomes a disaster or turns into something even bigger. So I hope we've been able to explain the difference between the ICU and the IMU and what it means to not be ICU sick but not be stable. Hope we didn't scare you too much, but I hope we were able to that you gained some information and
some
insight into what the IMU, the step down units, looks like behind the scenes, and you'll be better able to advocate for your family member or your loved one the next time that they're admitted into the IMU unit. Okay? Thank you so much for watching. If you're watching this on YouTube, be sure to subscribe and like this video. Thank you for everyone who has been subscribing, commenting, liking the videos. It has been helping us grow, and we would love to continue to grow this community. So please subscribe and like the video. Leave your comments, questions, concerns that you have in the comment section. And if you're listening to this episode on Apple Podcasts or Spotify, please be sure to follow and like and leave us a review there as well. We greatly appreciate it.
All right, we'll see you on the next episode. Stay tuned for more discussion to come.
Yes. Take care.
Take care.
Bye.
Bye.